Good afternoon. Thank you all for joining us today for this afternoon session. My name is Giovanna Braganza. I'm a research analyst at the United Hospital Fund, and it's my pleasure to now introduce this afternoon panel, Connecting People Who Are Incarcerated to Medicaid. This session will be moderated by Tracy Gardner, who is the Senior Vice President of Policy Advocacy at the Legal Action Center here in New York City. Tracy has spent her career in the health and social services policy sector as a policy advocate, trainer, and lobbyist. Without further ado, I'd like to turn it to Tracy to introduce the rest of the panelists and moderate this session. Thank you.
Thank you. I hope everyone can hear me. I usually don't have a problem with being heard. My outside voice is pretty adequate to the task. I'm sorry I'm not there at New York Academy of Medicine. I'm here in, I don't know, swampy Atlanta. But this panel I have been looking forward to since Chad and Giovanna reached out to me. So many thanks to United Hospital Fund for making space for this very important conversation at this very important conference. What we're going to talk about today is something that really fits in with the conversations that I've been hearing at the conference today about engaging communities and really being able to have the Medicaid program in New York be responsive and improve the health of communities all over the state. But Medicaid law, it's going to be 57 years old, has always had the Medicaid inmate exclusion as a provision, which, if you'll see from your programs in the overview, bars the use of or the billing of Medicaid for any care inside a correctional facility. There are a few exceptions, and without getting too wonky, for the most part, we have created silos of systems of care for people in communities that feed the carceral system. I learned about the connection between community health and correctional health when I started doing HIV work in the late 80s, because the corrections population, the corrections HIV and Hep C population reflected the prevalence in the communities from which people came, which was something like 80% from 5 to 7 neighborhoods and communities around the state. And that was something that I was taught by people who were formerly incarcerated and people who lived in the communities and also ended up incarcerated through our drug policies, our sentencing laws. And so for as long as there has been this criminalization of health issues, in particular substance use disorder and mental health, we have created these bifurcated systems where community health is inextricably linked to correctional health, but we have separate systems to treat the people who are who flow in and out of these venues, if you will. So we as a country, certainly in New York, have developed workarounds the Medicaid inmate exclusion in ways that we don't even realize we have had to adapt. And this really became apparent when New York embarked on its Medicaid redesign, and to learn that the movement of behavioral health into Medicaid managed care did not take into account the very large impact of people who flowed in and out of the criminal legal system, the justice system. Those of us who work on justice issues don't like to use the word justice, but that there was a whole population being missing because you couldn't base care based on their utilization of the Medicaid system. And that has a lot to do with the whole notion of Medicaid suspension and termination. And all of this came out as we were looking to make Medicaid redesign part one actually real, and as ACA was unfolding and providing opportunities to incentivize states to expand Medicaid coverage. And in many cases, this coverage, the Medicaid expansion has allowed people who have a lot of interaction with the corrections and law enforcement system to get coverage in a way that has been very challenging. So this is one of my, at the risk of sounding a little bit morbid, but it is my favorite thing to talk about, because I do believe that this recognition and this opportunity of the 1115 waiver and the awareness of the connection between correctional and community health that has been kind of brought forward very dramatically through COVID and the overdose epidemic means that we can actually do some game changing, if you will. But it is critical that the health sector recognize that although you may think you're not serving people involved in the criminal legal system, you are, and they're often having more touch with the criminal legal system or the correctional system than they are with your health systems. They cannot be excluded or forgotten about. And so we have an opportunity to use the pilot nature of the 1115 waiver to demonstrate that we can provide care that keeps people out of corrections, out of the criminal legal system, or as Patsy Yang has talked about, that the correction system not be the healthcare provider for communities whose health we're trying to improve. So I have the pleasure of being able to host a panel with three of my favorite people to talk about this stuff with. So this is just an everyday, ordinary conversation that I get to have with Jeff and Dr. Yang and Dr. Shavit. And now you can be part of it too. And then we'll talk about some next steps and some opportunities. So first, I'd like to introduce, or who'll be starting remarks first, is Dr. Shira Shavit, who is the executive director, founder of the Transitions Care Network. And she'll talk a little bit about TCN. It's one of my favorite models of engaging community members and folks who've been formerly incarcerated and work with federally qualified health centers in a way that's really instructional and a model that needs to be as widely adopted as possible. And then I'm going to have Jeff Coots, who runs Punishment to Public Health at John Jay College of Criminal Justice. I call him my work husband because we coordinate so much on different opportunities and talking to providers and people who are, working and living at the intersection of health and justice, and really staying on top of all of the developments where we can improve health and rely less on carceral systems for care. And then finally, my hero, who refuses to wear the capes that I sent her, Dr. Patsy Yang, who is doing the thing, which is working with people involved in New York Medicaid system through the Health and Hospitals Administration of Correctional Health Services. So Dr. Yang gets to see folks in and out and can really can talk very voluminously about the opportunities that we have taken advantage of and many that we haven't in really addressing the health and well-being of folks in communities that are affected by incarceration and by the criminal legal system. So you will get nothing if you don't understand how game-changing we are, we're at the point of where a discussion and a recognition of the role of Medicaid in improving the health of people involved in the criminal legal system. 10 years ago, people told me there's no way we're going to be talking about the Medicaid inmate exclusion. It will never be revised. We'll never open up Medicaid law to address it. And in fact, we have been deeply involved in federal legislative proposal called Medicaid Reentry Act, which is based a great deal on advances and conversations that have happened in New York. And, you know, I hope Jeff will talk about where that is right now. But the fact that there's federal legislation initially sponsored by Congressman Paul Tonko is something that we would not have imagined could be possible, which is to make Medicaid available for billing 30 days prior to release from incarceration. Now, we'll talk about, you know, the fact that there's differences between the prison population and the jail population, but New York really has an opportunity to be a pioneer on this work, although other states are definitely looking at these opportunities, including through the 1115 waiver, to address the needs of this population, to address the high risk of overdose and other comorbidities that face this population, and that fragile time of leaving corrections and transitioning into the community for health. And that is especially acute for people who are in and out of the jail system, which is a shorter stay. And again, I need to stop talking because all of the experts that you need to hear from are here. So I want to set the scene, set the stage, let you hear a little bit about how the panelists got involved in this work and what their background is that brought them to this work. So Dr. Shavit, would you mind starting?
Thank you so much, Tracy, for that introduction and that overview. I want to thank the United Hospital Fund for having me here today as well. This is really exciting. And for all of you, you know, in the audience, so I can share a little bit about my work. I am Shir Shavit. I'm a family physician and I'm faculty at the University of California in San Francisco in the Department of Family Medicine. And I'm a primary care provider. I came to this work because my practice is based in Bayview Hunters Point in San Francisco, which is a historically Black African-American community that was disproportionately impacted by incarceration. And we were seeing that even though we had access to care in our community, people coming out of prison and jail were not utilizing the health system. And so in 2006, along with my colleagues, we embarked on a process to hear from the community of how to transform our health systems to better meet the needs of people coming out of incarceration. And so my work as the executive director of the Transitions Clinic Network really focuses on the role of the primary care system in caring for the health and well-being of communities disproportionately impacted by incarceration. And what we do is we support a network of primary care clinics, federally qualified health centers that have all implemented our evidence-based model of care in their practices. And they're committed to transforming what they do to meet the needs of the community and partnering with the community to ensure that patients utilize services in the community. And so our model of care, as I mentioned, was developed in partnership with community members in San Francisco in 2006. And it essentially is an evidence-based model of care that embeds community health workers with lived experience of incarceration into primary care teams. And this is because the community said, you know, we need to be at the table when you are designing programs, but not just designing the programs, when you're implementing programs and when you're evaluating. And that community members need to be there continuously throughout the development and provision of services to ensure that the voices of communities that are so marginalized by these systems are heard and that systems are developed to meet those needs. And so it's not surprising that we've had good outcomes from this model of care. We found that our program reduces emergency room utilization in the first year post-release. In a randomized control trial with our program, our patients had 51% fewer emergency room visits in the first year post-release. And in a subsequent propensity match study, we found that patients in our programs in the state of Connecticut had fewer preventable hospitalizations, were hospitalized for almost a day less, and had fewer probation and parole violations. So we're less likely to be in the criminal legal system in the first year post-release. They spent 25 days less. And so that's a little bit about our program. To date, we've worked with 48 primary care systems in 14 states and Puerto Rico to implement this model of care. And these are all systems that are dedicated to transforming and partnering with communities. And that includes 3 active sites in New York, which I'm happy to talk about later. And so with that, I'm going to wrap up, but I hope just to share a little bit of perspective where I'm coming from, and I'm looking forward to sharing more about this work on this panel. So thanks so much, Tracy.
Thank you, Shira. Actually, could you also throw in a little bit, and this is for Jeff and Patsy as well, about how Medicaid supports the work that you do with this population?
Yeah, absolutely. Thank you. You know, as we all know, with the Affordable Care Act, that was a game changer in the communities we serve, because many people who are incarcerated did not have access to Medicaid prior to expansion of the Affordable Care Act. So many of our patients now, in most states that we do work in some non-expansion states, now have access to care. But what I think is really interesting is the data around this shows that access of care, that Medicaid card, is not always enough to get people in the door. And so our work is really focused on that engagement piece. And then the question is, how do you leverage Medicaid to have engagement into systems? And so we're really excited about this new potential of the 1115 waiver. Probably, I would say, when thinking about Medicaid, probably the most robust work that we've done has been in the state of California, where our prior 1115 waiver was whole person care and allowed for use of Medicaid dollars to pay for community health workers with lived experience of incarceration. In Los Angeles, for example, where they were embedded into primary care systems as well as into community-based organizations. So now moving forward in California, we're poised, we've submitted an 1115 waiver to turn off the Medicaid inmate exclusion policy in the first 90 days pre-release. And in addition to that, to also have what we call enhanced care management, so that when individuals come out of incarceration and they access services in the community, they have this enhanced team to support them, which could include community health workers with lived experience of incarceration, which addresses the complex medical and behavioral health conditions that people have, in addition to addressing what we call community supports or the social determinants of health. So I'm really leveraging the Medicaid system to think more across the whole spectrum of reentry and serving these complex patients.
Thank you very much. Jeff, can you talk a little bit about your background in working with different parts of the criminal legal system on behalf of people involved, and how Medicaid figures into the work that you've been doing?
Sure, absolutely. So, hi everybody, my name is Jeff Coots. I direct the From Punishment to Public Health initiative at John Jay College. Thanks to Tracy for inviting me to this event. It's great to be joining Dr. Shavit and Dr. Yang and everyone from United Hospital Fund and the audience there. So what we focus on at P2PH is we try to provide a platform for interdisciplinary dialogues that are focused on the intersections of public health and public safety. And alongside that, we work to position public health solutions to be responsive and even accountable to public safety issues. So one of the most consistent venues where we foster this dialogues is through the New York City Health and Justice Working Group, which I co-chair with Tracy Gardner from Legal Action Center. And this is comprised mostly of alternative to incarceration and reentry service providers in New York City, and then the healthcare, housing, and employment service providers that they refer their clients to. We also have representation from managed care, health homes, some of the larger hospital systems, and then government stakeholders who are working in similar domains. And we're trying to make sure that, one, we're all aware of the opportunities and challenges that are present in the environment where we're working. And then it's an opportunity for some of the government stakeholders to announce some of the new strategies that they have or resources that they'll be rolling out in the coming months. And so that's a great venue for us to be having these conversations on a regular basis. More recently, we launched something we're calling the Cross-Sector Advocacy Group, which draws members from mental health, substance use, housing, and criminal justice reform agencies who are doing budgetary and legislative advocacy at the city and state level in New York. And obviously, kind of in each of those conversations and efforts, there's a lot of discussion about how we can leverage Medicaid as it currently exists, or Medicaid as we can reimagine it to better serve the communities and the individuals and their families that we know don't operate in siloed existence. They touch all of these systems. And it's important for people who are providing direct services in these sectors, and for those who are setting and implementing policy in these sectors to be in regular communication. I think one of the more direct areas where we've been involved most recently has been in our work with the Kings County District Attorney's Office in Brooklyn. And so they have a program called Project Clear, where there's a peer dispatched to a precinct in the aftermath of an arrest for simple drug possession or petit larceny, so shoplifting as well. And the peer goes and engages the client and tries to get them to engage in some productive service, some positive service modality. And if they're able to do that, the district attorney will dismiss the case before the arraignment even occurs. And that prevents the individual from having a record, a public record of that arrest. And then it also gives the opportunity for the peer to engage the client and get them connected to service. And quite often it is getting their Medicaid turned back on, or getting them reconnected with their health home care management agency, or even reconnecting them with one of their substance use or mental health service providers. And so in a lot of ways, we are identifying clients who are coming through the criminal justice system and trying to understand how their underlying health and behavioral health needs can be addressed through the positive touch that we have with them, and kind of turning the negative touch of the police and court encounter into a positive one through many of the providers that we work with.
Thanks a lot, Jeff. And so, Patsy, I don't even know that we are going to do this whole, your background in working with this population. I think we can go right ahead to, you know, kind of what the challenges are that you face given where you are and what you're able to do. I mean.
Sure, Tracy, thanks. So, you know, our just very quickly, our you know, daily census hovers around 5,000 to 6,000 people. You know, average, the median length of stay is about 25 days. We are very often, correctional health services, we're part of Health and Hospitals, have been the direct provider, not through contract, since 2016. And the idea there was really to eliminate or start smoothing out some of those silos that Tracy, you mentioned at the top of this session. We are very often the first encounter that people have with an organized healthcare system short of an ED visit. And that presents both an opportunity and obligation to really screen, identify, diagnose, treat, cure where we can, stabilize people as well as we can before they leave. And you know, most of the people who are in the city system are pre-trial. That is something that people may not realize. We're not a prison, we're a jail. And so the fact that we're very often the first encounter with the system speaks, I think, again, Tracy, what you were saying earlier, where, you know, we are by default or by comparison to the capacity in the community for people who are sometimes the more marginalized among us, end up being the large healthcare provider. And that is just, I think, the whole purpose of this conversation today, and all our work is to rebalance that. Medicaid, you know, jail is just an awful place to be. It's not good for your health. We start discharge planning day one to try and get people out as quickly as possible, to stabilize them, to work, as Jeff, you were mentioning, you know, alternatives to incarceration, working with prosecution, defense, and courts to support release. Medicaid in New York State, in a progressive state like New York, we are federally, precluded from federal fiscal participation, which I think is the point of this conversation. Medicaid is permitted for overnight 24-hour stays in hospitals. So if somebody needs acute inpatient stay, Medicaid does kick in. people leave our custody and care with 4 months of Medicaid fee-for-service, after which you drop off unless you're enrolled. I think that's an opportunity to discuss as well. You know, the question about 30-day rules, part of the logistical challenge of something like that is, again, we are a jail, not a prison. It is more chaotic. It is more uncertain. The time that you're in custody is highly variable and highly unpredictable. So you don't, it's not like in prison where you know ahead of time where 30 days are from the day that your sentence will be up, you'll be released. So that can cause some challenges. I think it's a great incentive for municipalities that don't currently have sort of the in reach from CBOs currently to incentivize. New York City, we are very, very lucky that the city has historically and continues to support the kind of robust work, social, human, health, broadly defined services that people need while they're in our care. So that would not be an incentive to us so much. But I would say that if 30 days by billing, that is a operational challenge that I think we'll probably discuss as a panel a bit later. I would say that a lot of the rules around Medicaid, I would caution against how applicable and amenable they are to a jail setting. The carceral environment is very, very different, where patients largely, you lose so much of your agency. Your ability to move to access care is regulated. It's very straightforward, but it is not up to you entirely. It is dictated by the carceral environment and the rules and regulations there, which don't always comport well with Medicaid rules. Those rules, I think, still, but to a much lesser degree, apply to community capacity, which again, I think is what I see as the most important part, which is, again, correctional health services, we provide really good care. We stabilize people. We cure more people for hepatitis C than most states in the country. Stabilize folks who have mental health issues, substance use issues, and do all this discharge planning. And then there is, apart from Dr. Shavit's networks and providers like that, really a lack of a paucity of community capacity that is willing and able to serve patients. And we are talking about access, not just in a temporal manner, easy weekends and evenings, but walk-in appointments. We're talking about temporal. We're talking about geographic accessibility. The city of New York, with these 5 boroughs and cosmopolitan urban areas, densely populated, have healthcare deserts. We have healthcare deserts here. We're talking about linguistic accessibility. We're talking about cultural accessibility. And I think also being aware that we're not stigmatizing people, even while we need to recognize and accommodate the special needs and traumas that people suffer when they've been engaged in the system. I think possibly the most attainable piece is really Medicaid, active, unsuspended Medicaid day 1. I saw in some versions of the 1115 some requirements that the state agencies have some obligation to make sure that Medicaid is active day 1. That remains, despite our beginning that process on day 1 of incarceration, a challenge. And if you are released unpredictably, but enough time, even within hours or days, that you don't get access to your medications, that can be a problem. And we compensate a CHS with walking meds and things like that, but there's a limit. Right. So I'd say active Medicaid day 1 is critical. Flexibility and understanding of the Medicaid rules that, if applied in jail, acknowledge the carceral restrictions and constraints, but to encourage community capacity by having Medicaid rules that permit a little bit more flexibility of the kind of breadth of service and flexibility in service that patients who are just leaving a really restrictive, very different environment, very chaotic environment in some ways, need that extra support, again, without stigmatizing them. I think in correctional health services, similar to Dr. Shavit's model, we have our port clinics, our port practices, which are port points of reentry and transition service. We base them in our mothership facilities of currently in Bellevue and in Kings, and are increasing those numbers of port clinics. They are like the transition clinics, I think, culturally, temporally, geographically accessible. We also have the added advantage of allowing our own providers and correctional health services to work in those practices, so that you get to see the same doctor who saw you when you were in jail, and have that trusting relationship already built. And currently Health and Hospitals has pending before the state a special populations request that carries this idea of integration between community and correctional services systems, another step farther through a value-based model that includes an IPA and CBOs and community providers. So I should probably stop there and get into the conversation with everyone.
Yep, because there's more. There's so much more to talk about. But I mean, again, if nothing else comes out of this discussion, it is when we talk about some cultural differences, we're also talking about the culture of corrections and the criminal legal system and the culture of the health system. And, they are not connected by technology. They're not connected by outlook. The carceral systems are about custody and control. There isn't autonomy in appointments. There is a whole way that healthcare is rendered inside, even the best healthcare rendered inside by a correctional health services is still constrained, as Patsy pointed out, by the carceral environment. And that also, again, the idea that people are accustomed, that this population then becomes accustomed to getting their care that way, which then makes it a challenge to access the care that we are developing through our 1115 waivers, through our transformation of healthcare systems. Where does that leave people who are coming out of these systems? 80% of people come back to their communities from corrections. This is not, this cannot be the sole responsibility of corrections and the carceral system to be a healthcare provider. We must shore up supports in the community. But if healthcare doesn't see, I'm not gonna say a value, but if it doesn't see a way to get paid for providing the care, then that has been part of the challenge. So many of the inroads that we've made to connect correctional and community care have been done with grant funds through city, state, and federal. And we have, as Patsy said, we've been successful with Hep C, we've been successful with HIV, we are developing protocols with COVID, but correctional health in general is not overseen or administered by health. And there is a disadvantage, a severe disadvantage to individuals who are in and out of these systems when that's not the case. Jeff, could you talk a little bit about what some of the opportunities and advantages that we might be able to accomplish under the 1115 if New York's amendment proposal is approved? Well, it will be proposed, it will be approved. So when it's approved, what are we going to be able to do?
Absolutely. So the latest version that we saw when it was released for public comment at the state level placed the priorities for criminal justice populations within the broader health equity framework. And so what we were looking to be able to achieve there is 30 days of targeted in-reach pre-release for all settings. So that would include both jails and prisons, and to include the first 30 days of jail. And that was a learning from one of the health home pilots in the district program that I'll talk about a little bit later. But what we'd be able to provide during those 30 days is care management, clinical consultation, peer services, and medication management, including high priority medications like long-acting injectables for schizophrenia and opioids dependence. So what this would really allow us to do, if you think about what just that transition of care looks like, and for those of you who work in community-based settings, thinking about what best practices in discharge from a hospital setting to a community-based care provider would look like, right? Ideally, you're going to have in-person in-reach that facilitates that warm handoff. And so Patsy referenced that this in-reach is grant funded or state funded. We have some agencies that are funded to do this work, but they're really just looking to make connections to the community-based care provider themselves. What we would be able to do with this Medicaid waiver is have the community-based agencies themselves conduct some in-reach so that they can make that face-to-face connection and start to build some rapport with the clients. And then they'd also be able to set an appointment post-release for that individual to come to their clinic and to engage in services. And this is one of the, and then I'll say the last thing that we would be able to have is better outcomes tracking. We'll be able to capture, are the connections being made post-release, are clients showing up for their appointment, and that would all be integrated into the Medicaid billing system that we would be able to study better. With the existence of the Medicaid imminent exclusion policy, everything is a workaround. And so all of the great things that Patsy and her team have built are workarounds because we don't have Medicaid funding available to serve this population. One of the things we learned through the health home pilot that we ran with 4 health homes and correctional health services back in 2018 was that individuals who were in jail with health home eligibility, we identified 3,000 health home eligibles that had come through the jail in a 6-month period. 700 of them were active with the health home, and we were able to send 600 alerts to the CHS discharge planners to connect them with the care management agencies if they were so inclined, if the clients were interested in it. And we made 120 connections in the first quarter that we attempted this. So the numbers go from 3,000 that we were seeing go through to only 120 connections. And in looking further at why that was happening, what we learned was that the turnover rate for people cycling through the jail was incredibly high, that even though we were identifying them and looking to engage them, they were often released within a few days from the jail. And that's something that we see a lot in jail settings, is the quick turnover. And that's one of the reasons that we pushed for the first 30 days of jail to be covered by Medicaid as well, so that the community-based provider could follow the client into the jail setting and continue their community-based care. And then the last thing I'll say on that piece is something that Tracy alluded to earlier, which is that, I mean, obviously in New York City, we have the resources to fund this additional workarounds. In most areas, particularly in rural areas, you're not going to have that level of attention, that level of resource. And so what we see is that the quality of care that's provided, the standards of care that are provided in carceral settings are much lower than are available in the community-based setting. And so by bringing community-based providers into the jail setting, we will naturally be able to see some of those standards of care rise. We'll still have those challenges of the carceral setting where clients don't have as much agency as we would like, but by bringing community-based clinicians into the jail to engage with the jail-based providers and vice versa, we get to see some improvements in the quality of care there.
Fantastic. Thank you, Jeff. One of the things, Legal Action Center worked a great deal with the state players on recognizing the needs of the justice-involved population. And the joke was that at the time, Jim Introne, who was Deputy Secretary for Health, and Liz Glazier, who was Deputy Secretary for Public Safety, basically said they didn't want to know, they didn't understand or want to know about each other's domain. So Liz Glazier's like, don't try to teach me about Medicaid. And Jim Introne is like, I don't know anything about the criminal justice system. And, you know, there has been, this was 2014, 2015, when this conversation was really happening. There have been trying to explain the flow, if you will, of people involved in the criminal legal system, whether they end up in jail, whether they go to court, when they're on, the difference between probation and parole, pre-trial. All of these things are terms and kind of circumstances that aren't known to healthcare. And the opportunities for healthcare in those different stages are not really clear. And then we have on top of it, this restriction of Medicaid, utilization of Medicaid or use of Medicaid to actually render the care. And again, developing these workarounds, really it's duplicity, it's not efficient, and folks who have the least ability to advocate and be quote unquote patient advocates, informed patient advocates, get the worst care. So for me, this is also where the health sector must and has to step up. And one of the recommendations for the waiver, based on the past, and Jeff, I hope you'll talk about this a little later, is that it's not the justice involved population is not an optional population to work with, right? You're seeing them whether you think so or not. And to the better equipped and advised you are about the nature and the impact of incarceration on people being able to navigate healthcare, the better. So Shira, I'd love for you to talk about, you're working with FQHCs all over the country. So you're probably hearing about some of, or many of the challenges that the providers either anticipate or are encountering when they're working with this population. So what are some of those issues, and what is the recommendation or support you give them to work it through?
Yeah, great, Tracy. I mean, I think one thing I just want to touch on is sort of this point about how providers in the community don't understand carceral systems, and there's a lot to be learned. I think one of, and so there's real opportunities. And then, I think Jeff mentioned there's also an opportunity for carceral systems to learn from health systems and potentially improve what they do. I think though there's a risk here, which is that community health systems don't end up not being the lead in this process, or health systems are not the lead, but the carceral systems lead. And in fact, health systems can inadvertently become sort of the arm of the criminal legal system. And I think this is a really important perspective from the work that we do and that what we've heard from our community, because some of these best practices of what health systems need to do were really defined early on in the work we did with our community. And kind of one of the things, in addition to the community saying, we need to be at the table in the design, implementation, and evaluation of these services, we need to transform, primary care services. They also said we want to make sure that the health system doesn't replicate the punitive nature of the criminal legal system. And the reason they were saying that is that as, Black and Brown communities in very largely under-resourced communities, the community has felt that sometimes the health system is punitive or treats them poorly, or they feel stigmatized or experience discrimination, based on the color of their skin, based on their diagnoses like mental health or substance use disorder, based on their history of incarceration. And there actually is a study, there's many studies that show discrimination because of people's criminal legal history in the health system. But there was one in particular that as a primary care provider always hits home with me, which was actually done in Canada, where there's universal coverage, universal access to care. But when patients were calling clinics and saying they had a history of incarceration, they were half as likely to get an appointment in the clinic. So we really also need to look at our health systems and transform what we do in the health system to make sure that we're meeting the needs of the patients. We can't just assume that because we're sort of health oriented or, that we necessarily are not inadvertently kind of stigmatizing patients, that people don't feel like they're still system impacted when they come to the health system. And so a lot of these best practices as defined by the community were, to embed people from the community within teams to help with that ongoing transformation, to address the needs of people more broadly. So to ensure that you're not just focused on their medical conditions as far as physical health conditions, but also the behavioral health conditions. And in many jurisdictions, that as you mentioned earlier is siloed. So how do we ensure that behavioral health treatment is provided in those settings as well? What we also, heard from the community was that it was important that the services were provided in existing health systems, not separate, right? They don't want to be treated differently. They want to come home and sit in the waiting room with their family members and community members. And so these were kind of some of the core values in thinking about the work we do. So these partnerships are really critical, but it's how do we ensure that we're also transforming our practice to meet the needs of the community, not inadvertently, replicating those systems. And so a lot of our work is around, and I'll stop in a second, but I think Patsy has something great to add, which is just, I think, how do we transform those systems, and make sure that the voice of the community health workers in the community is meaningfully embedded in those systems. So that's system transformation is key, I think, to the success and the engagement of patients into services.
Yeah, I didn't mean to distract you. Sorry.
Oh, no, it's okay.
I totally agree about that. The independence of the health system is incredibly important. I mean, even one of the real advantages of our situation right now is we have in New York City, we've always been separate from corrections. So that is a critical tension that's always there and needs to be maintained. I just wanted to, I know, and the 1115 is really focused on the services, Jeff, that you were talking about. Medication really important, but case management, all that stuff for in-reach. It remains, and I can't touch what you said, sure, it was just, it is so hard. The minute we say Rikers, it doesn't matter where, what kind of continuity, what referral, what appointment we're trying to do, whether it's a skilled nursing placement or referral for home services or housing or an appointment in clinic or anything, it is that additional stigma. And the 1115, it's great. It's just like, I don't want to lose focus on the fact that the community, the capacity, whatever it takes to have that will and capacity of community providers to change and accept our patients, it's not going to get fixed until we have somebody to take patients and keep them as stabilized as we can make them. And people are going to end up with us because there's no ability to support and stabilize people in the community. You shouldn't be in jail because you can't keep yourself well in the community. That's right. Sorry.
So don't apologize, Betsy. That's exactly where I was going to go to you with. We have let's say a beloved curmudgeon that we know who has posited that very cynically, but that healthcare sector will not and has not cared about this population until there is a dollar sign associated with them. And so, in many ways, that is coming to be true, which is if we can actually neutralize or deal with this provision, the Medicaid inmate exclusion, in a way that really allows for healthcare to be reimbursed and to see the financial benefit. It's certainly a financial and moral benefit to the communities from which folks come from. And the impact on public health is so significant, but we only look at it in terms of payer systems and kind of what the data shows. But I think what we're really all talking about is how missed this population is. So I was hoping that Patsy could talk about how payment systems can be improved to better engage with this population. And then I guess we're going to go to some question and answers unless people don't have any questions, and then we're just going to keep on talking because that's what we do.
Yeah, I mean, I don't think it's anything different. I think the notion and where the system in New York State has been going, towards value-based and outcome-based is the way to go. So we're not encouraging meaningless encounters by chits and counting on the process piece, particularly if you're talking about a patient population who, might need some of the wraparound services that aren't traditionally considered to be within the medical realm. We're all public health people. We know that on the cost basis, it's very short-sighted to keep thinking about that cost and not the longer and more expensive cost for care unprovided, right? And if we can focus on community capacity and incentivizing networks in the community where there's a horizontal and longitudinal vertical integration where you are accountable for the outcome of your patient, to avoid that more costly disease burden down the road that's inevitable if we don't intervene early. I mean, what dollar you put on preventive care and primary preventive and secondary preventive has always been a conundrum for us public health people, right? To put a dollar sign on it in this market economy. But that is what we're talking about. And there is no population that is more in need and ready and ripe for this. That's it.
Can I just add one little thing
Please.
to that? So, yeah, I mean, I want to underscore that. And I think the payment mechanisms, though, it has to sweeten the deal. It has to be easy. I mean, I think, when I hear, in our state, we're implementing enhanced care management, and I'm hearing, people are, the burden of documentation, for instance, is so high. And then you have community health workers, and how do they document? Or we're trying to pull in CBOs to do this work, which is phenomenal to use Medicaid dollars, but then the billing for a CBO around this work, or that whole spectrum from incarceration to community has to be one payer, not multiple payers, right? So I think the complexity and how these payment systems are implemented really also need to hear from the providers of, like, will they use it? Because if it's too complicated or too difficult, if for a population that they don't want to serve, they're not going to necessarily come to the table. And I think that is a really important point that Patsy was talking about. And I just really want to underscore that, because I know there's a lot of policy folks on this call. So thank you.
Yep, absolutely. Okay, so my handlers are telling me we're moving to question and answer, and I see that there are 2 in the Q&A box, and folks should, weigh in. We've got like major brain trust here. I think one of the questions is that work with health homes still going on? Jeff?
Sure. So I think one thing that was good from that is the health homes themselves maintained connections with the partners at CHS. And so that ability to kind of flag clients who are coming through that may be health home eligible, and then make those check to see which health home they might be assigned to, and then check those things. I think one of the things we learned was that because the CMAs were not allowed to do in-reach services, they could be connected for a case management conversation, but they couldn't physically go and meet the person, which was the best practice, that we turned our attention to the Medicaid waiver and the Medicaid Reentry Act. So there were some, I think, lasting benefits from that pilot. We learned a lot about what the challenges would be, and that is in some part how we shaped the criminal justice priorities for the waiver itself.
I just want to add something, though, that around the 30-day while you're in jail, I'll say it, which is access in the carceral setting remains a challenge, and relationships count on consistent presence on a daily basis and access to build that relationship and trust. It's hard enough for people who are working in the jails to do that. And I think it would be exponentially harder for community providers coming in to do that. That's just a reality, at least of the system as it is now. And so again, I'm going to say that whatever can be done inside the jail is great, but there is a precipitous drop once you leave that system in terms of the healthcare system. There's nobody to catch. And it's not, I think, in a perfect world, you establish relationships from day one, from the beginning. You walk in the ideal world, you're never even in jail. But if there are going to continue to be security and safety and access issues in jail, the focus has to be on who's on the outside catching and preventing incarceration in the beginning, and avoiding and supporting people so they don't get reincarcerated, and that all the progress that somebody might have made in jail, ironically, I absurdly to think about that, but clinically stabilized and in care, doesn't get degraded once you get released, and then you cycle back. That is awful. That's awful.
And we keep coming back to this issue of, it is not even so much technology as it is the Byzantine nature of the Medicaid, not data sets, but the Medicaid system, and this issue of the ease with which we should be able to reinstate people's Medicaid to full coverage to allow for them to access the care that they need. So as was mentioned, there's people can access care in the community if they're incarcerated. They can access care at a hospital if they're there for 24 hours. And that in New York is the suspended status. So I'm at Bedford Prison, and if I need to go get care at Westchester Medical, the Medicaid that is assigned to me will be in a suspension status, which is basically hospital only. And that is also then why people have been utilize emergency rooms in a way that certainly goes against what we're trying to achieve with the triple aim, because that's the only coverage that they have. There are community providers who want to see an active, full Medicaid in the, I'm sorry if I'm confusing the system, the eMedNI system, before they will take them on. There's some providers who will retroactively bill, but there are many who don't. So the mechanics and the promise of this, whether it's through the Medicaid Reentry Act, the federal piece, or what we're going to do with the 1115 waiver, can't be realized unless the mechanics are addressed. And they haven't been sufficiently. There are many stories of people having to do individual interventions to get Medicaid active for individuals who've been in the community for a while. And with overdose, this is absolutely basically consigning people to almost certain death.
And I just have to note, sorry, that I neglected to
Sure.
say in the beginning, which is that in New York State currently, Jeff, the first 30 days of incarceration, Medicaid is still accessible right now. Not in jail, but but there aren't providers that, so if one of our patients needs specialty care on a consultation or something, we'll make an appointment with providers in the community. Nobody wants to do that. So we end up with our wonderful sister facility like Bellevue doing that, and Bellevue can bill in the first 30 days for that outpatient specialty visit. But that in and of itself, again, Jeff, it's not, I think we better push it a little farther.
And so I think on that point, one of the things Tracy mentioned earlier was the optional versus mandatory nature of serving this population, and that's something that we're looking for. So in DSRIP, right, the first round or the last round of the Medicaid waiver, there was a roadside diner menu of priorities that the PPSs could choose to pursue and seek funding for and prioritize. In the current structure of the HEROES and the social determinant networks, what we would want to see is that each SDN and each HERO must have criminal justice population priorities in order for that plan to be improved and funded by the state. And so that would require the people who are thinking about systems change to be thinking about how they're going to be serving this population. And also really recognizing, this goes a bit to Cesar's question, that because of what Patsy mentioned earlier too, about sometimes quite often they're the first service provider, healthcare provider that these individuals have seen in quite a while outside of emergency rooms. The Medicaid spend is going to go up for these groups. And so we have to be realistic about how we are structuring value-based payment contracting for these individuals as well in the next round of Medicaid, because they have not been engaged with service providers that are billing Medicaid historically. And so their Medicaid spend is going to go up, and we've got to be cautious about how we prioritize that or structure those next round of innovations.
So we're going to have to wrap up this session soon. Thank you so much for joining us for such an engaging discussion, to Tracy, Dr. Shavi, Jeffrey Coots, and Dr. Patsy Yang. Thank you.
Okay.
I know it's late in the day. This is the home stretch. Thank you so much for those of you who remained with us. But for those of you who watched kind of the Marvel movies, you know that if you stay till the end, there's a special treat. We do have a special treat for you this afternoon. We're going to have some closing reflections and remarks from one of our lead sponsors, the Commonwealth Fund. For those of you who are involved in health policy, you know that the Commonwealth Fund is basically the North Star for thoughtful analysis and information on U.S. Health policy. So I'm particularly delighted that representing the fund is Melinda Abrams, Executive Vice President for Programs. I think, Melinda, you probably taught me all that I know about using strategic philanthropy to shape healthcare policy in practice. So without further ado, Melinda.
This is camp season, so all of you deserve like a gold star or a badge for, passing the conference endurance test. And you may all kind of go water skiing or skiing in deep end or whatever. Many thanks to the United Hospital Fund for its continued leadership as a reliable hub for policy research, data analysis, stakeholder convenings, all of which help us in New York, but also across the country, identify and discuss viable options to improve healthcare and health of all New Yorkers. I also want to quickly thank my fellow co-sponsors, particularly the New York Academy of Medicine, for hosting this event and for their ongoing work to innovate public health. The Commonwealth Fund, as Tony said, is a national foundation, but has its home and its heart here in New York, and continues to think that the health of New Yorkers is a top priority. Medicaid is the largest health insurance program in the country. And since states have the primary responsibility for overseeing and implementing Medicaid, they are the leaders. States are the leaders in how we design and deliver care. New York State continues to be at that cutting edge and has been for a long time in terms of how it tests different approaches and different different ways of integrating and improving care. Some quick takeaways from today's conference. From Amir Basiri, what I heard a lot was New York's ambitious plan, and very clearly stated, to continue to fill these coverage gaps that we have. New York is a more progressive state, but there continues to be coverage gaps, to scaling the value-based payment, to promoting these social determinants of health networks, and increasing the community engagement. I also heard, and Chad mentioned this when he was moderating, the theme of trust came up over and over again, whether we're talking about between plans and providers, or among different providers, or health providers and community-based organizations. And what, of course it's challenging, but what was so nice and inspiring about today was to hear examples of how it is improving and how it's possible, and what it takes to get done, and some of the timeline. What I also heard loud and clear is, while there's a lot of these innovations and going on at the community level, also the ongoing importance for the integration to succeed is the importance of the systems. And that is in many ways the role of the state Medicaid, or kind of at the county, is to provide that really solid foundation on which that enables those community partnerships to flourish and thrive, and also to scale. The other piece, it was really refreshing. I go to a lot of meetings and I hear a lot of people talking about, people and patient-centeredness and person-centeredness. And what was refreshing really today was to hear how that is very much happening and very present in New York, and the focus on the person experience and the person's needs, and putting in the center as design, quality and equity, and trying to advance equity, and it focused on in the goals. The last is about sustainability. It comes up in every conversation. Pockets of innovation are fantastic, but how do we scale them? And what I heard loud and clear again was the importance of both workforce for things to be sustainable, and how the entire team, whether it's peer navigators or community health workers, and how that's really continuing to grow, but also the importance of data and reliable financing. So I'd be remiss if I didn't mention that as the national landscape changes and progressive reforms become more difficult, our reliance on states increases. And it's so easy right now in some ways to kind of be a little bit distressed or deflated, maybe a little depressed, with how the status of the national politics or the status of healthcare reform. But today, at this conference, this UHF Medicaid conference, provided a lot of hope and optimism. You know, a fair bit of light in what often feels like a little bit of darkness, or a fair bit of darkness. And I found today's discussion about collaboration and innovation and change both inspiring and hopeful, not just for New Yorkers, but also an opportunity to share with other states around the country. So finally, I just want to say thank you. Thank you to the providers. Thank you to the community-based organizations. Thank you to the agency leaders. Thank you to the experts. And thank you to all of you for what you're doing, because I'm walking away with a healthy dose of optimism. So thanks.
All right, we're done, but just bear with me while I just do one last round of thank yous, just because it's so important. Thank you to all the speakers, the panelists, you, the audience. You're what makes this conference so special. Thank you to our sponsors, again, the Commonwealth Fund, the Academy, Amita Care, Minette, Unite Us, and particularly thank you to my staff. And I know I read their names out aloud earlier this morning, but they're so important to me. So I'm just going to run through the names again. Kathy Arns, Hillary Brown, Adam Fifield, Miles Finley, Hollis Holmes, Gabby Grunk, Emily Regas, Joey Rodriguez, Sally Rogers, but particularly the staff of the Medicaid Institute, Alex Brandes, Emily Arson, Giovanna Braganza, and Chad Shearer. So thank you all again. I hope you have a great summer, and we hope to see you again on October 25th. That is our annual research symposium. So please come back for that. Thank you.